Hope everyone is calm now because I get to deliver the most boring and maddening 2 hours. So I hope we're coming into it calm. Arrived in Tennessee in the fall of this year. I also served as the director of the Pain Medicine Fellowship at Michigan State University. For the time, I think it was one of 2 DO pain medicine fellowships in the country, so we were proud of that. I am going to be delivering 2 lectures. The first one was my partner, Dr. Blake, who's in the process of moving, and I got told I was doing this about a week and a half, 2 weeks ago, so I apologize if I'm not totally familiar with his slides. The second one will be mine. Should be pretty interesting because I think you're going to get both a narrow flavor of how we got to where we are, excuse me, and maybe a broader picture on opiates and where we have come to. So appropriate prescribing in Tennessee for narcotics, suitable, appropriate, befitting, relevant, germane, and applicable to the patient. My only disclosures are I'm a current consultant for a neuromedical device, but it has no impact on today's lecture. So, why has opiates become such a huge problem? Well, opiate sales and use have gone up, both medical and non-medical, quadrupled from 1999 to about 2010. I'm going to be giving you more data in the second lecture about where we've come from there on. But also, in lockstep, opiate overdoses have quadrupled as well during the same time period. Substance abuse treatments are also 7 times higher than it was in the beginning. Non-medical use have cost insurance companies a lot of money. Drug overdose, a leading cause of death in 2013, surpassing car accidents or homicide. 63,000 Americans died from drug overdose in 2017, and that number is increasing. If you look at one thing as a statistician that kind of irks me is whenever somebody presents statistics, I think everybody in their own brain has their own correlation coefficient. So if you see things that kind of going up together, then we immediately go to causal interaction. But if you do look at, say, the sales of opiates from 99 to 2010, they were on an upward trajectory along with deaths and treatment admissions for overdoses. So in your head, those all are linked and are causal. In Tennessee, where the opiate epidemic has hit more severely, rose from 6.1 in 1999 to 18.1 per 100,000 population, compared, and it overtook the national rate. If you look globally, the U.S. has a very big usage of opiates, where we are almost 100% of the world's hydrocodone consumers, over half the world's oxycodone consumers, 61% of the Dilaudid, a third of the methadone, and half of the buprenorphine. So how'd we get here? In the 90s, JACO came out with pain as another vital sign. We were forced to both monitor pain and treat pain as a means of getting reimbursed. But if you look at addiction rate amongst all drugs, even if you say, I'm not even talking about, say, marijuana, but even like cocaine, heroin, addiction rate has hovered around 10% no matter what decade you kind of look at the data. So that's kind of held the same. And then the higher demands on us as physicians to treat the pain, see more patients, get them in and out of the office so we can meet all of our other demands, puts pressure on us to maybe not look at the entire picture or see if the patient is doing things that aren't, say, healthy. Patients are getting older. There's more obesity, so there's more downstream effects to that in terms of spinal degeneration, joint problems, especially now with the financial and the emotional problems after the COVID epidemic. Depression is extraordinarily high, and so has financial problems. So, why are opiates becoming such a greater use? Well, there's a lot of untreated psychological disease. People are using these things to mask maybe other psychological or emotional pain. The use of narcotics in terminal cancers be condemned if it can possibly be avoided. I'm gonna just say during this first lecture that I will disclose that I am biased. A lot of the things in here, I don't have the same sort of take that Dr. Blake does, so I kind of wish he was giving this lecture so you'd have a little bit more back and forth between us. I do agree with this. If you're giving somebody an opiate, one of the things that I think we avoid, or I think of the problem as we started to treat more pain, was we weren't exactly, what were we following, right? Following a happy patient, but not necessarily doing scores or things that would look at, patients' functional life, quality of life. What's your VAS? Oh, it's no better. Let's just keep going up. Okay, let's increase the dose till you're happy. I think we went, our internal sort of gauge was more patient satisfaction than it was actually looking at, say, scales of their quality of life better. And by the way, if you have questions in the middle, I'm all for interrupting and not saving it to the end. But if you look at drug overdose deaths, there's been an increase, and I agree with that, from 2012 to 2016. If you look at overdose deaths by race and gender, they're predominantly white and predominantly male. And as I told you, I get frustrated with statistics. If you look at the overdose death rates by the contributing substance, and let's just say the year doesn't matter, but if you look at, say, all drugs, right, does anyone have a problem with kind of the numbers that created that? Does anyone sort of does it jump out to you that those numbers don't add up? Right, so in 2016, 1,600 drug overdose deaths, but almost 1,200 of them were opiate, another 1,000 were prescription, right?
How do they delineate between fentanyl and prescription opiates or just opiates?
Another great question, right? So if you look at, there's been actually lots of studies when they look at, because fentanyl, as we're going to get to, is very common in, quote, opiate deaths, but if you look at the source of the fentanyl from the black market street, or where the patients who have died have gotten this fentanyl, it hasn't been from the U.S. supply. Because the U.S. supply of fentanyl doesn't really exist in powder form. The U.S. supply of fentanyl exists in, liquid form and surgery and patch form. So most of those are teased out because they weren't opiate prescriptions. But we're being beat up over the prescriptions.
So is it basically, if someone has an opiate overdose and they find fentanyl in their system, is it automatically considered fentanyl death, or is it if fentanyl's over a certain limit that
Yes.
Oh,
Again, there's statistics and there's lies, right? And I can create any subset of, as an epidemiologist, I can create you any subset of statistics to try and fit my hypothesis, right? And what I don't like about this is it doesn't quite paint the whole picture. In the next lecture, I am going to get I'm going to delve a little bit deeper into that exact question. If you look at by age distribution, I'm at the peak of it, which I don't know why, because I think life's a lot better in my 40s, especially during the med school time. Said I was so broke I couldn't pay attention. So again, opiates present in overdose deaths are very high. In the next lecture, I'm going to get into, what is that exactly the problem. Opiate deaths by fentanyl analogs have been increasing. Anyone have any sense of why fentanyl might be increasing in terms of people who've died from a drug overdose death? How many people tailgated in college? Come on, be honest. Yeah, 2 hands, I love it. So if you tried to sneak something into the stadium, were you sneaking in, 8 beers, or were you sneaking in like a flask to put in your Coke, right? Right. You're going to pick the more potent agent because you can sneak in a smaller amount and get the same effect as the 8 beers that you never make it through security with, right? So the same thing happens in, prohibition, right? The drug dealers, it's so much easier to sneak in this much carfentanil than it is to sneak in, a truckload of heroin. So I can sprinkle the same amount of carfentanil into whatever you just bought, and if you thought it was heroin and it's now, 10,000 times more potent, you died. So so basically, along with that, you have these mobile pill manufacturers, and they can now create that little bit of carfentanil. Can I go back? And create fake pills. In fact, we had a patient 2 weeks ago trying to pan off their old aspirin tabs as they're dilaudid. So, basically you can stamp these things in these mobile units to look just like it, and if you're somebody who does drugs recreationally, remember 90% of all drugs, including cocaine, heroin, are non-problematic use. But if it's a non-problematic use and you do it on the weekend, say at a party, and you think you're taking the same amount of oxycodone that you took last weekend and you felt okay about it, but now it has carfentanil in it, you had an inadvertent overdose. So, small changes to it, and carfentanil actually has a lot more use in the veterinary sense because they're using micrograms of it to be an analgesic for elephants. So you can imagine what it does to a 70-kilo human. So what are the things that sort of lead to, problematic use? Substance use disorders are very preventable. Again, I agree that they are a brain disease, as is addiction. Very much tied to the limbic system and the risk-reward centers. So basically, substance use is a state in which an order derives on a compulsive behavior. There has to be compulsion. There has to be an abnormality in the risk-reward circuitry such that there's basically harm to the life of the individual. Notice how in the definition of addiction there isn't really a substance tied to it. In the 20s, there was a bunch of research by Skinner where he put these rats in a cage. It was called a Skinner cage, incidentally. And he gave the rats 2 choices, water, just basically water, and then he had water laced with morphine or cocaine. And Skinner noticed that the rats would preferentially go to the water and cocaine or morphine, and a ton of them died. And that was sort of the agent theory of addiction in the 20s. And that lasted through till about the 70s. So about 50 years, we thought drugs changed your brain to cause you to become an addict, and then you died. In the 70s, an astute psychologist said, you know, it doesn't really make sense if you take an animal that is inherently studious, engages in exercise, loves to be interactive with fellow rats, and loves to build dens and form families. So they created this rat heaven, right? So that they had a whole bunch of sawdust and things for them to make dens. They had exercise wheels, they had cheese and different kinds of foods, and they had males and females, and they had families, and they, toys to play with. And they gave the water and the cocaine water back, and none of the rats died. So, basically if you take away what it means to be a rat, and then they have no purpose in their life, yes, they overdosed on cocaine. But if you gave them purpose, or they were able to participate in the things they enjoyed, they voluntarily chose not to do that. Same thing happened in a human study in Vietnam, where the U.S. was terrified of bringing home the soldiers because the heroin addiction rate was so high. It was like approaching 50% in overseas soldiers. The U.S. was petrified of bringing them home. But when they came home, the addiction rate amongst that group, just that group of the ones who were addicted, fell to the normal national rate of 10%. Once they got home and they were back with their families and in a safe place and felt they were safe. Yes? Right, if they were in rat heaven, they wouldn't have overdosed on the cocaine water. Yeah.
I'll give you a little bit of history. I'm kind of curious to start with. I graduated from St. Louis College of Pharmacy in 1960. I've seen all this stuff develop. There are two books to read. One is a book by Norman Ohler called Blitz, O-H-L-E-R, Blitz, Drugs in Nazi Germany. They were actually, when the German troops went on the blitzkrieg, they were hopped up on meth. Before the war was over, they were making a pill of meth and cocaine. And the whole Germans, they had ads. Women, if you can't get your housework done, take this little pill. So World War II, our drug problem in the United States really started, I think, due to the Joint Commission issuing this ridiculous pain scale. I've had them come in occupational medicine and say, well, if 10 is the highest scale number, how much you heard? 15.
I'm actually going to get to the broader picture of that in the second part.
A book to read about this is one called Empire of Pain. If you want to really see how all this stuff started, it's the Sackler family. And Empire of Pain, the book came out, and that exposed the Sackler family, and that's what brought all this stuff about. But you really need to read this book. Now, getting back to World War II, the United States Army, before the war was over, was giving our troops 1 to 2 million amphetamine tablets a day. World War II. Okay, we go forward. I have a nephew that was a Harrier jet pilot in the opening battle of what am I trying to think of? I'm getting older now, so you know I go back that far.
Do you mind if I just keep going, though?
He was a Harrier, graduated the Academy of the Marine. He was a Marine Harrier jet pilot. Went in on the opening battle of World War of Iraq. And he said, as fast as we could land and take off, and our planes were resurfaced, armed and serviced. And he gave credit to the people taking care of the planes, because they didn't lose a single plane due to the captain bomb. And he said, oh yeah, they gave us that little pill to keep us alert.
Do you mind if I just keep going there for a minute? I'm sorry.
These two books, I don't know if you know about them or have them or go bring them up. Everybody needs to get those two books and read them.
Thank you. A lot of studies based on, trying to figure out if there's a biological, genetic versus environmental component. Although from an epidemiologic standpoint, if you look at, say, like, okay, children of alcoholics are 4 times more likely to develop addiction problems than the general population. But yeah, how do you tease out the fact that they were raised in an addictive environment? So it's very, very difficult to tease that out. They've even gone so far as to try and actually develop twin studies where the twins were separated and raised in different households, but there's just not enough of those out there to really get an N high enough to actually compare the two. So they are correlated. There are some genetic factors that may play a role. As an epidemiologist, I always say it's genes and environment. The traits of addiction is sensation-seeking, impulsivity, loss of self-control, harm avoidance. They don't take care of themselves. They have aggression. They steal. And they're actually highly intelligent. Things that lead to it are these adverse childhood experiences, and the amount of adverse childhood experiences, if they increase, then also the likelihood of substance use disorders increases too. Like depression, diabetes, heart disease, obesity, suicide attempts, partner violence. Length of postoperative opiate exposure has also been associated with large increases in misuse, although I'm going to show you more data on that in the second lecture. In a study where 570,000 patients receiving post-op opiates, they looked at refill, and each additional weeks of refills showed an increase in rate of misuse of 44%. Although when you get asked or presented these data, you should always ask yourself, how did you define misuse? Because as a statistician, I'm always fascinated when I find out how they define something. Like when they present hunger data, the federal definition of hunger has nothing to do with marasmus or a calorie reduction. It has to do if you're unsure where your next meal is going to come from, and heck, I have unsure where my next meal is going to come from. Brain functional studies of patients who aren't addicted, who are, do chronic drug over consumption, shows reduction in brain activity. And then it takes, even at 100 days of abstinence, which is at the bottom, you start to see restoration of function, but not quite back to normal levels. Again, if we look at the definition of addiction, it has nothing to do with the substance. We debunked the idea of the agent theory of addiction, right? So addiction could be anything. It could be gambling, could be sex addiction, porn addiction, benzos, opiate, drug of your choice. It's basically that self-harm, the avoidance, the impulsivity. Again, gambling, work, food, sugar, right? Video games. I might have fallen into that at one point in my life or not. Prevention, early identification, treatment, relapse. I disagree with the last one. I think government tends to induce more harm than it does good. I'll actually show you data on that in the next lecture. But there are screening tools you can use in your office. The CAGE, the opiate risk tool. With the CAGE, I believe, does all. CAGE doesn't necessarily have to be alcohol. It can be, any agent. Where the opiate risk tool is really just benzodiazepines, opiates, things like that. And you can download these and use them for free in your office. Because everyone pretty much is familiar with CAGE, I'm assuming, right? Cut down, annoyed, guilty, eye opener. If you have 2 or more, then you're at risk of having alcohol addiction. And then to intervene and get them screening, intervention, and referral to healthcare professionals. But of course, try and tell somebody they need help and see if that happens. So CSMD, again, I'm biased when presenting this, but these lectures are going to tap into the part of your brain that tries to do a correlation coefficient. So the Controlled Substance Monitoring Act of 2002, all healthcare practitioners shall register that if you have a DEA number and you prescribe more than 15 days in a calendar year. Your PAs, your mid-levels have to have a supervisor, and we have to sign off on it. Basically, you have to check it if it's a new course of treatment more than 7 days, at least annually. If you feel that the patient is doctor shopping, diversion, or misusing, you can also check your own report to see if there are people checking it in your name. You are not required to do it if it's a 7-day supply with no refill. So if you're in surgery or your emergency medicine and they have a real reason, they have a broken arm, you don't have to check it. You can put it in the medical record for your medical legal documentation and any action that you took. You will get notified if one of your patients has used 4 practitioners in the last 90 days to alert you if maybe they're doctor shopping. 5 or more pharmacies in the last 90 days. Greater than 120 milligram morphine equivalents. So, again, we're showing you that the amount of registrants to CSMD from when it was initiated till now has gone up 4.5 times, or 4 times. Law enforcement has made fewer requests because supposedly we're doing our job. And the dispensed, at least opiates have gone down. MMEs have also decreased since CSMD. Again, these are correlation coefficients. We'll get into whether or not it's causal. So if you look at the change from 2010 to 2016, 17% drop amongst Tennessee patients for long-acting MMEs. Also a drop in the short-acting. So this applies to all class 2 to 4 opiates, benzos, Ambien, barbiturates, and Soma. The person who gets it has to have an ID, but does not require the person who it's prescribed for to pick it up. For a pain clinic, the medical director has to be a pain medicine specialist and board certified. Although ABMS or AMA currently is the only certified specialties. We have to supervise all the mid-levels. It's non-transferable. Only pain medicine specialist can be the medical director. We can't have a pharmacy on the premises, and we are, I think, the only medical specialty in Tennessee that has its own office site visits. That's a lot of fun. So again, ABMS or AOA, you have to be anesthesiology, PM&R, psychiatry, and neurology. I think the AOA only recognizes anesthesiology, although I couldn't tell you since the merger. Yes?
That's incorrect. The AOA, I'm just retired as the chair of the Prosecuting Bureau of Aesthetic Specialists. They recognize all those specialties.
Oh, it was probably 4 or 5 years ago when I was director of Michigan State. I had a neurologist call me up, and I called our department and I said, I don't know. And I was told we couldn't take a neurologist. So that might be new.
No, that's not even new, actually.
Oh, okay.
It's always been the case.
Oh, those same specialties?
Yes.
Oh. Although now it just doesn't matter, right? Because it's all merged.
Well, no, postgraduate education
Right.
accreditation has merged,
Yeah.
certification has not.
Oh,
AOA has a separate board certification program from the ABMS.
oh,
Yep.
guess I need to learn more about that. So patients treated with 120 morphine equivalents are 11 times more likely to have adverse health outcomes, and morbidity and mortality. With a seemingly increase in risk over 40, and guidelines require anyone over 120 to see a pain medicine specialist annually. This is a little bit frustrating to me, and maybe in future conferences I can sort of give a lecture about the mixed agonists and antagonists and how they're changing the scope of what an opiate is for current research. But in Tennessee, buprenorphine, even as a sole agent, can only be used for opiate use disorder. Of course, unless it comes in the form of Butrans or Belbuca, which, even though it's the same molecule, under those formulations, it can be used for chronic pain. Only pregnant women, nursing mothers, or patients with documented history of reaction to naloxone may get buprenorphine. Any obstetricians in the room? I know the American Society of Anesthesia and the American College of Obstetrics and Gynecology have, like, basically said, like, if you're on chronic, like, even if it's a at-risk drug, like, maybe you should stay stable on it. I don't know if you can, is that basically still the recommendation?
Yeah, for the most part, I guess it's individualized. Most of these patients we refer down to Vanderbilt where they have like a specialized clinic and things of that nature, so they're monitored close down.
Yeah. I know from the anesthesia standpoint, we're like, just stay the course. I have some frustrations over the buprenorphine, but again, that's a whole different talk. So we also have civil immunity. You can prescribe naloxone to an at-risk patient, family friend, or other person in a position who can be in a position to administer it. This is sort of a busy slide, but requirements to prescribing if you use a 10-day opiate prescription with 500 MMEs over the total 10 days, so 50 a day. You have to check the CSMD. You have to have a documented evaluation. You have to show that you talk to them about alternative treatments, informed consent, and you have to have an appropriate ICD-10 code. Or a 20-day supply with 850 MMEs, you have to do that too. A 30-day supply, 1,200. So a 3-day supply of opiate prescription at up to 180 MMEs, no requirements before prescribing. So this is just really a recap of what we just did. So exemptions to the rule is patients receiving active or palliative cancer treatment or hospice care or a diagnosis of sickle cell disease, patients under the care of a pain management specialist, patients treated with an opiate greater than 90 days in the last year, patients who are doing medically assisted treatment with methadone, buprenorphine, or naltrexone, and patients with severe trauma or burns. Tramadol is now a controlled substance as well. Dr. Blake is one of the people on the steering committee for chronic pain guidelines. And it applies to all healthcare providers except, obviously, palliative hospice care. You can look up them yourself. Prior to initiating opiate therapy for non-malignant pain, establish the diagnosis, have a H&P, labs imaging to support it, show that you're using non-opiate approaches first, Continuation by itself, if you're taking on a patient from someone else who says, I've been on this for a long time, isn't quite enough. And telemedicine shall not be used to treat chronic pain. And you've got to consider there are other health conditions for, like, say, COPD patients have a hyper response to sedative medications more than you would expect from patients that don't have COPD. Assessment of risks of abuse. There's a bunch of different ones. There's the opiate risk tool, which is the easiest. There's the SOAP-R, which is a little bit more sensitive and specific, but it's very hard to, it's time consuming to administer. The ORT is a lot easier. But you also have to check their urine. You have to make sure that the agents that you're prescribing are in their urine and not absent from their urine. Patients who are filling monthly and don't have the hydrocodone that you're filling 4 times a day and they're filling it monthly is not present in their urine. So you got to make sure that that's there, that they're not possibly diverting, that they're not using, you know, other drugs of abuse from the street, and CSMD.
Question.
Yeah.
How do you differentiate possible diversion in someone who needs it twice a day, 5 days a month, and one script lasts 5 months?
Right. So there are different sort of, as an aside, my brother was undercover narcotics for 4 years. So it was interesting being a pain physician and my brother being a narcotics officer. But what they'd like you to do is dispense a month's supply. So, you know, if you have a patient where you're dispensing one a day and they're using it sparingly. I'm not saying this is right. I'm only saying what strategies to avoid something like that is to find out and have a frank discussion about how much they need it per month. Well, you use 7 tabs per month. I'm going to dispense you 7 tabs. But then you run into the problem of, okay, 1 PO daily, PRN for pain, dispense 7, and then they come back. Is it an early refill? Not really, based on your prescription, right? You just didn't dispense them enough, and this month I used more. So yes, it can get difficult, but as somebody who uses 7 tabs, you know, a problem. And then the other thing is you have to document, if you take their urine, when their last tab was. Right? So if they say there's a 3-day detection window. So if somebody took a tab this morning, they might have, say, hydrocodone and no metabolites. If somebody took it 3 days ago, you don't expect there to be parent hydrocodone, just the metabolites. So you're hoping that the story that they're giving you matches what you see in your testing.
But you tend towards prescribing as many as they think they will use
In a month.
less than 30 or 60.
In a month, correct. And again, I know we sort of talked about this earlier in the talk, but what is your endpoint? Not just patient satisfaction, but I always ask my patients, hey, what's your goal? You know, like, you know, I'd really like to stand at the stove and make dinner. So that is in my chart, and it follows the patient with every visit. I'm like, hey, are you standing at the stove and you doing dishes? Are you making dinner? Are you able to vacuum? You know, have we hit that endpoint that you came in here in the first place for? Because maybe your pain isn't necessarily as reduced as you wanted, but that's because you're a ton more active. So again, interfering with enjoyment of life, general activity. You have to be concerned at risk of overdose, starting at about 40 MMEs, greatly increased risk from 80 to 100. Start with intermediate acting versus long acting. Benzos will increase the chance of an opiate death, and this is actually fairly well studied by about 10-fold. Not just and there's always the excuse, well, I've been taking, 5 milligrams of Xanax a day and, 10 milligrams of Percocet 4 times a day for the last 10 years. Sure, but now I got a cold, and now I just took NyQuil, and that was the thing that tipped me over the scale. So in the studies of, overdose, just the presence of a benzo and an opiate increases the chance tenfold. So if you're starting an opiate therapy, you start low and go slow. You do a trial. You say, okay, let's start with a low dose. We tried all the other stuff. Okay, we're going to start, say, Tylenol 3 or a 5 milligram hydrocodone. They come back in a month. And you see if there's a response, right? Maybe there's a response. Maybe there's a little bit of response. Maybe we'll try 7.5. But if you're not getting somewhere, this isn't like a step function, right? Where you get absolutely no response until you hit 500 morphine equivalents and all of a sudden it's working, right? Usually there's a slow progression. Again, we talked a little bit about pregnancy, opiate therapy, single provider, single pharmacy is what you want your patients to use. You don't want them shopping the pharmacies either, paying for cash. You typically, what I would teach the fellows is the 4 A's. You want to make sure analgesia, that it's working, that their activities of daily living are improving, that they're not having adverse effects, that they're not having any aberrant behaviors, and then affect, I guess, how they're acting towards you. So again, monitor for aberrant behavior, ongoing risk assessments. You might want to repeat your opiate risk score. And if patients of childbearing age, you can offer that as well. Again, screen pregnant women. It is the neonatal abstinence syndrome is becoming a bigger problem as well. But it's interesting, and in the next talk, I'm going to show you some of the longer-term data on prescribing and dispensed drugs. And look at that, the CSMD, we're identifying more. We identified a lot of doctor shopping early on, and as that has become a thing, this is sort of that, correlation coefficient in your head that's supposed to tell you that CSMD has decreased it, right? Pain management clinics, the numbers have gone down, mostly because they're also going after pain management clinics that aren't sort of up to snuff. Although I just showed you all this data, but then I show you the next slide that drug overdose deaths continue to rise. I'm going to get more into that in the next talk. Impact on pain patients, right? I mean, we're asking them to make all these concessions, right? With now the government's getting involved and telling us how many morphine equivalents there can be, and you have to do this and you have to do that, and we're raising the bar and the headache for the patients, and their quality of life is decreasing, or at least what they're reporting. And more of them have now said they've considered suicide based on all this. Prevalence of chronic pain, 11 to 24%. Lifetime prevalence of spinal pain from 54 to 80%. The average persistence of low back pain, 12% children, 15% adults, 27% in the elderly, so it does increase as we get older. And it is a huge cost to the healthcare system. Interestingly, from 97 to 05, there was no improvement in self-assessed health status, disability, functional status, if you look at it amongst patients who complained of spinal problems in 97 to 05, even though there were more opiates being prescribed. So opiate, long-term therapy for patients with neuropathic pain disorders. Opiates haven't really been shown to be helpful except at extremely high doses, so you have to start them low and keep increasing them to a very high point where it actually starts to have a slight impact on neuropathic pain disorders. So a patient who has, history of neuropathic pain, laminectomy, smoker, they're on disability, they probably have a lawyer for this, and whether or not opiates are going to be helpful for that patient. Again, good history and physical, diagnostic studies. Some point maybe in future talks would be good to go over like nociceptive versus neuropathic pain patterns. I don't know if you see at the bottom, there's a pinched L5 nerve root. Bogduk is an interesting guy, but he's very opinionated, but he says it's also treating the patient. The difference between preventing acute pain from turning chronic is often a matter of treating the patient nice and convincing them there's nothing horribly wrong with them. I don't necessarily agree with him. But interestingly, all pain, no matter what it is, studies show 90% will go away within a year, whether you do something about it or don't do anything about it. So that even calls into question the difference between acute and chronic. Chronic, if you look in a textbook, it says anything over than 6 months. I happen to disagree with that, is anything that lasts longer than the expected duration. And I had a wife who had a 2-level cage fusion of her neck, and I can tell you that the recovery from that is more than 3 months. Again, classification of pain can really be can be separated into nociceptive or neuropathic pain, and the treatment algorithms are slightly different. Non-pharmacologic, pharmacologic interventional options as well. Non-opiate analgesic options include muscle relaxants, anticonvulsants, NSAIDs, acetaminophen topical, anticonvulsants. And what's interesting, if you look at this slide, and one of my problems with, say, the WHO stepwise progression of pain control is that if you look at this slide, virtually everything on this slide only applies to nociceptive pain conditions and not neuropathic. So if somebody comes to you with a hot L4 radiculopathy from an L3-4 disc herniation, the only thing on this chart that has actually been shown to be helpful is the bicyclic, tricyclic antidepressants. So it really depends on which pain algorithm or which pain the patient's presenting with. Acetaminophen, 3 grams per day maximum, although some pain societies are even saying make it 2. The problem with it is that there are 2 molecules or 2 mechanisms of action, I'll say, in medical treatment today that is presenting a real problem. One is acetaminophen, which I think we're recognizing, because you got patients on 4 grams a day of acetaminophen. Again, then they get a cold, they take an over-the-counter product and get a hot toddy, and they show up in the ER with yellow skin. The other one is serotonin, because so many patients are on some kind of antidepressant. Then they're given Flexeril for their muscle relaxant, which is, has serotonergic properties. Then they're given, then they take a cough medicine, dextromethorphan, has serotonergic properties, and all of a sudden they're tachycardic and hyperreflexic, and they're not feeling too well. Tramadol as well has serotonergic properties. The other non-opiate options have real problems in terms of ceiling effects and analgesic activity. There is a real thing of kidney and GI side effects. Tricyclic antidepressants, which are some of the best norepi reuptake inhibitors we have for the treatment of pain, are very difficult to use in those over 60, but can be really helpful for those who have problems with sleep hygiene, fibromyalgia. Carbamazepine, oxcarbazepine, topiramate are voltage-dependent sodium channel blockers. Carbamazepine will auto-induce its own metabolism, so as you give them more, they actually respond to it less, whereas oxcarbazepine doesn't have that side effect. More of the first line are the calcium channel blockers, gabapentin and pregabalin. Capsaicin, which is what makes habanero pepper hot, has been shown to be really useful in diabetic neuropathy and postherpetic neuralgia. Lidocaine topical IV. I'm going to Although I'm sure Dr. Blake would love me to spend a lot of time on the interventional stuff that we can use. I'm gonna go through this a lot, but you know, we can do selective nerve root destruction for arthritis, spinal arthritis, cervical, down to SI. There are large joint neurotomies that we can do for patients who either have persistent pain after, you know, knee replacements or want to avoid knee replacements, hip. And I don't necessarily agree with this pain cascade, because if you're leaving I have plenty of patients who come in and say, I want to get a shot. Hell, a year and a half ago, I had a back problem. I got an epidural myself, and I haven't had a problem since. So I would have rather done that than medication. I don't have to talk to you about non-pharmacologic treatments to a bunch of DOs. Co-prescribed naloxone with clinically appropriate. I don't know that the data necessarily supports that, although I do it because it's rule here in Tennessee. But you know, if you're on a plane and you don't have a parachute, would you jump out? How to taper. So, pain physician, I think in Florida, just got dinged for how quickly they went to taper. But the effects of withdrawal from opiates tends to last about 5 days. So if you need to taper them aggressively, typically I'd taper by 5 to 7 day rule. If they've been on chronic therapy and you're tapering them because they just want to try coming off, then it'll usually, depending on what their dose is, make it a 2 or 3 month affair. Yeah.
Question on tapering. So, like post-surgical, that aspect, right? Like you're giving someone a 7-day supply, but you're not tapering them. So, how do you reconcile that? Because you're only allowed to give them X amount.
Well,
Does that include?
theoretically, 7 days isn't quite enough time to develop a high enough tolerance to make withdrawal symptoms really severe. So,
Theoretically, in reality.
but again, withdrawal symptoms, even at high doses, have been shown to be, they're not life-threatening. Not like, say, alcohol or benzos are life-threatening.
But I'm saying, in order to, I mean, I understand tapering to avoid withdrawal symptoms, but even just tapering people off safely so they don't get hooked on it.
Right, if you're only giving someone a 7-day supply, I wouldn't be concerned.
Okay.
Because they almost auto self-taper, right? You know, the first 72 hours are bad, maybe they're taking it Q6, right? And over the last 3 days, they're like, oh, I only need it 3 times a day, 2 times a day. I need it once when I... That's the hope, right?
All right, fair enough.
Yeah. Again, withdrawal syndrome usually starts 2 to 3 half-lives, 6 to 36 hours. Most severe at 24 to 72. And again, last 3 to 7 days, 5 days being pretty much norm. I'll give a patient a clonidine patch, 0.1 milligrams, 24 hours, try and help with withdrawal symptoms. You can also give tablets, but I'm always nervous giving somebody a very dangerous drug like that, you know, especially if they're having withdrawal symptoms and they might think, well, 1 clonidine pill should be 5 should be better, right? Which is probably a lot more dangerous than putting down 4 Norco. Psychological support is very important when you're going to taper. Make sure they get counseling. Rotate patients to things that you can change more often rather than the fentanyl patch. Although there's a lot more options now in dose schedules to do it with fentanyl. You don't want increasing, decreasing crescendo patterns for, you know, taper. You got to be careful of diversion to family members and trivial complaints. Categories of misprescribing on our part, impaired physician, disorganized, dysfunctional office, dishonest for financial gain. Duped is, I think, probably the number one, I think. Dodging, I think, is a real thing, too. Oh, my God, I don't want to see this patient in a month. Here, take 3 months. Drug-seeking behaviors are definitely a real thing. Patient don't have interest in the diagnosis. My favorite ones are the ones who get overly angry and the ones who think you're the greatest doctor that ever walked the face of the earth. Oh my God, I've seen so many doctors and no one's ever found this about me. You're the only one. They just hit you with flattery. Yeah, that's real. Oh my God, I got through that in an hour. You guys want to take a quick break before we get to the second part? Or do you want me to motor through? Any questions?
What's your take on the latest Supreme Court decision involving overprescribing dogs?
I have to say I'm not familiar.
They voted 9-0 to turn over in lower court of a doctor who got life for running a village. So a lot of these dogs are getting out. I'm not sure life is a fair sentence for prescribing pills, but
Oh, right. I did see that. So I'm gonna try and check my bias here, but I'm a government skeptic. I've been toying with the idea of sort of writing an op-ed on this actually very topic. I question whether or not our mantra of do no harm is appropriate. So I guess it depends on who you think that the final decision maker is in healthcare decisions, right? Is it the government? Is it the doctor? Is it the patient that you're treating, right? And the courts actually go through a battle with themselves when making some of these decisions, trying to stick to a long history of honoring natural law, where the person has the inherent right to make that decision on what they put in their body. Our duty, and this has been supported by Supreme Court decisions, our duty is to tell the patient risks, benefits, alternatives, including the option of doing nothing. And then, once we've done our part, they got to decide for their own body what's appropriate. So I agree with you. Putting a doctor away for life might be a little bit harsh, but at what point are we paternalistic, and at what point do we honor self-autonomy? I'm not saying there's an answer, but I tend to lean more towards the self-autonomy.
I agree.
But I'm happy to listen to dissenters too. So we moving on? Okay. Yes, sir. I actually gave that exact lecture at CHI 2 weeks ago. Opiate-induced hyperalgesia is definitely a phenomenon. I gave this lecture, Side Effects Beyond the Package Insert. So in to make everyone go back to medical school, and Rex head lamina 5 of the dorsal horn is where sort of the widespread pain centers are. So like when you have that propagation of the pain beyond the dermatome or beyond the damaged part, and NMDA and glutamate are the primary receptors and neurotransmitters involved there. Opiates of all types increase the expression of NMDA and Rex head lamina 5. So you have to be really careful in patients who are hyperalgesic to begin with, because you could worsen their problem, like in fibromyalgia, and patients who, it's strange because each opiate is different, and it seems to be increased by the potency of the opiate, the speed of onset, and the speed of offset will increase whether or not somebody will become hyperalgesic. And when you're in that phenomenon, it's difficult to see it in the beginning. Even the physician who may know it tends to see it late, and the patient never sees it. Now, I need more opiates. When you give them an increased dose, they come back, I'm not better, I'm worse, and now you have to either, you're looking at ketamine, methadone, taper, try and sell the taper, and buprenorphine, which one of my sticking things about Tennessee is I'm limited in how I can use buprenorphine in sort of those instances. But yeah, opiate-induced hyperalgesia is definitely an entity. Any anesthesiologists in the room? Because we use a drug called remifentanil, which has a onset of seconds, given IV, and an offset of 1 minute, and it's like 150 times more potent than morphine. So we started to see opiate-induced hyperalgesia even in opiate-naive patients in recovery and post-op, a lot more often because of remifentanil.
I gave a lecture at the American Association of Tennis Players, and I came across lipoprotein A, and erythrogram actually helps that, but it actually decreases pain. So if your patients at least won't get an erythrogram brace, you may not use that bracelet very often, but it helps a whole lot of things. Like 31 studies that went into naive erythrogram helps. It decreases pain, even helps help you quit snoring. So you also check into earthinginstitute.net to see those studies. It helps with pain.
All right, so let's kind of take us, now that we set up the problem, let's kind of take a step back a little bit and try and take a more 30,000-foot view approach. And whenever I'm going to talk about pain, I always start with the definition, because I feel if you don't have a good understanding of the definition of pain and how the interplay works, then it's very difficult to figure out your treatment plan. And you'd be surprised how many anesthesia residents that come to rotate with me who are, because pain doesn't follow into their training pathway until they're a PGY3, so they're more advanced residents, and they come and none of them can define for me even what pain is, an anesthesia resident, right? And there's a lot to unpack here. This is the International Association for the Study of Pain, which is probably the most accepted definition. It's an unpleasant sensory and emotional experience. We're going to unpack all this. Associated with actual, potential, or just described in terms of tissue damage. Sensory and emotions, unpleasant sensory and emotions, they're linked. Pain is always subjective. It's based on your past experiences at the individual level. Not all unpleasant sensations have an unpleasant emotional response, right? Somebody might pinch you and you go, ow, but you're over it, right? Not all unpleasant emotional experiences have abnormal sensations. You might cry over the loss of a loved one, or after a grieving period, or you might not have any unpleasant, physical sensations, sensory sensations after that. Although some people move on to somatization disorder, right? Where they don't necessarily have biologic disease or an X-ray or an MRI you can get or something you can find other than they're depressed, and now that nagging hip is the thing that's leading their life, right? And again, noxious stimulation of nociceptors under general anesthesia have no emotional responses, right? So I can put a patient under anesthesia, surgeon can make an incision, heart rate and blood pressure go through the roof, yet when they come to recovery room, patient has absolutely no, emotional response to what happened, memory, or anything like that. So although in anesthesia, they always tell the anesthesia residents that anesthetic gases are not analgesics, but they might be pain relievers, right? So because it's a subjective thing that you base off past experiences, right? For women who might say, hey, I broke my leg, and I'm comparing that to delivering, where a guy's worst thing is I had a cold last month, right? So it's a 10 out of 10. So many people report abnormal sensory experiences that don't have any identifiable tissue damage: fibromyalgia, phantom limb pain, post-herpetic neuralgia, somatic symptom disorder, which we talked a little bit about. So if we take the subjective report of their pain complaints as indistinguishable from the tissue damage, right? Fibromyalgia, there's nothing you're going to find. There is still pain. So again, under that, the stimulus of the problem is not related to the pain. And it's interesting too, like you'll find people who have like early on degenerative discs hurt a lot more than people who are like 85 and now their vertebral bodies are sclerosed and they got end-plate hypertrophy and they've kind of fixed the swelling there. So like what about like somebody who's a paraplegic, they fell in a nursing home, they had a fracture of their right tibia, their body responds, right? They have a sympathetic response to the fracture of increased heart rate and blood pressure, but they don't report any abnormal sensations in the limbs, and they're not, other than like looking down and seeing, a compound fracture, they're not really emotionally disturbed by it, right? In that case, doesn't meet the definition of pain. How about masochists, people who have the abnormal sensory or unpleasant sensory experience but derive pleasant emotional response from it. My favorite one, I haven't been able to figure this one out. You hear a commotion in the other room. Honey, how you doing? I'm fine. There's an unpleasant sensory experience. There's an unpleasant emotional experience. But is there pain? Boy, that one went over horribly. So, acute pain tends to have information to the organism, right? Tells you something's wrong, tells you need to get out of there, limb, withdrawal reflexes, but chronic pain doesn't, it's something that extends beyond what you would think it would normally last. It has no really protective mechanism for the organism. It serves no adaptive purpose. It disrupts sleep and normal living. You can have autonomic hypersensitivity from it. And then we talk about analgesics, and if you think about the definition of an analgesic, it's a compound capable of producing analgesia that relieves pain by altering the perception of the nociceptive stimuli without producing anesthesia or loss of consciousness, right? So in this definition, it's saying that somehow an analgesic is something I can point to you along the spinothalamic tract. I can show you where it works. I can show you where morphine works. I can show you where an NSAID works. And that is an analgesic. And there are common analgesics we use, calcium channel blockers being your gabapentinoids, norepinephrine reuptake inhibitors, your bicyclics, your tricyclics. But not all analgesics or not all things that relieve pain are necessarily analgesics, something you can point to in the pain pathway. And this is sort of my definition of it because, like if I have a patient who has spinal stenosis and they don't do well walking or standing, I can give them flexion exercises and make themselves a more hunched posture, and then they can be more functional and have less pain. Although I can't tell you where that works in the pain pathway, it is helpful. People with fibromyalgia get massage, whatever, it helps. I can't point to in the pain pathway, meditation, biofeedback, mindfulness for somatic symptom disorders. So let's talk about clinical examples. 42-year-old comes with an acute disc herniation, right? They've come to you and they failed the normal stuff, the PT, the ibuprofen, the tramadol, right? Is Norco an analgesic? Can you point to it in the pain pathway? Yeah. Is it a pain reliever in somebody with an acute hot radiculopathy? Unlikely. So narcotics don't really work well in that patient population. So they don't necessarily all go together, right? But what about Cymbalta, duloxetine? Is it a pain analgesic? Yeah, I can point to you where it works in the pain pathway. Is it a pain reliever in this clinical vignette? Very likely. So like 35-year-old with fibromyalgia, again, failed PT, NSAIDs, failed Norco. Cardiovascular exercise. Is it an analgesic? Can you point to it works in the pain pathway? No. Is it a pain reliever? It's one of the best things maybe we have for, chronic hyperalgesia, fibromyalgia. Now, Trexone, which is the antidote to opiate pain relievers, is definitely not an analgesic, but it has been shown to be super helpful in patients with fibromyalgia. So just because something is an analgesic doesn't necessarily mean it'll work in that situation. Just because it isn't an analgesic doesn't mean it won't work. Clear as mud. My favorites are the nonspecific abdominal pain, history of childhood sexual abuse. Remember in the last lecture we talked about some of the things that would lead to substance abuse disorders. 20-year history of seeking medical care without clear diagnosis, loss of 2 jobs or not working, frequent ER visits. I'm giving you a total vignette of somebody who, wouldn't be a good opiate candidate, right? But after everything they tried, somebody tries a fentanyl. Is it an analgesic? Yes. But now that they've used the fentanyl, right, the vignette is bad for using it, but now that they've tried it, their ER visits are down 80% and they've gone back to work. So, thoughts on it being a pain reliever in this vignette? Yay or nay? It's a yay, right? The pain symptomatology has changed. Remember in the first talk we looked at just not patient satisfaction, but what are they doing? In this case, the patient is not abusing the system. They're going back to work. All of their pain complaints are improving. So kids just emotionally damaged, they're fine. Okay, so if pain is personal, subjective, it does not require an objective causal factor and can be treated by agents not causing analgesics, how do we know how to treat patients, right? Well, patients sometimes will tell you, what they need, like NSAIDs and narcotics are more helpful for, say, nociceptive pain, arthritic pain, than neuropathic low back pain. So if you're saying, does this patient have spinal stenosis, or does this patient just have lumbar facet syndrome, right? Some of the history will tell you, if they said, Aleve, ibuprofen, heat doesn't work, probably not facetogenic, right? But are they also using drugs to mask the underlying psychological angst, which they do a lot of times? So if we're going to apply these concepts to the opiate pandemic, there's a lot of things that have sort of been assumed, right? The assumption is that we're responsible for the opiate pandemic. We've given somebody a Norco that has predisposed that patient to now become an addict, right? This is the agent theory of addiction, that now they're going to go out and seek heroin. So if that's truly the right hypothesis, right, then if we start decreasing the amount of narcotics we're writing, then we should fix the problem, right? We shouldn't be generating all these new addicts. So let's look at some of the data. And, you know, in the first talk, we sort of looked sort of up to the peak here, right to about this point, you started to see the drop. Well, I can tell you from 2017 to now, that number's like right here. So we're in 2023, we're actually down 50% in our opiate prescribing. So that's great. We're doing our job, right? So the days supply per prescription is falling. The average MMEs per prescription has been falling for over 10 years, and again, it's approaching probably about half of what it was. So pat ourselves on the back. But what's happening, right? If you look at intentional and unintentional opiate deaths have been increasing by all opiates over the same time span. So while our prescriptions are heading down dramatically, opiate deaths are on an uptick dramatically, right? So again, are we causing it, or is there something else going on? Actually, prescription opiate deaths have been plateauing for a long time, and this might be probably hard to see. Prescription opiate deaths, but if you look at illegal fentanyl, heroin, cocaine, and psychoactives, right, they're going through the roof. Yeah, actually that line is down here. So decreasing our prescriptions, which we've done our job on, hasn't resulted in the drop in opiate deaths that we thought it would have. So there's other assumptions, right? The assumption that prescription opiates now are the leading cause of death in opiate deaths. And I think somebody had the question of, like, what was the fentanyl and how do you tease out the individual ones, right? So if we assume that hypothesis is true, then everyone, when I was in public health school, they said there's two people you hate, lawyers and epidemiologists. And I'm not a lawyer, but I'm an epidemiologist. So in order for, I always test hypotheses. So if that's to be true, right? If we control for all other covariates, all the other drugs, our prescriptions should be the one that's left behind as like the aha, like that's the one putting people in their graves. So New York City Health Department in 2016 decided to do a look back. And they said, let's take all of the drug overdose deaths, 2016, and then let's look at them and see what were they on. But what's interesting is 75% of them had heroin or fentanyl in their system. Fentanyl, we already know from many other studies, are not sourced from the U.S. supply. So the fentanyl that's in these deaths are not from a fentanyl patch somebody slapped onto them, right? 97% of the quote-unquote opiate deaths in New York City in 1 year time had polypharmacy, right? So remember in the first talk when I showed you that, amount of total opiate deaths, but when you tease out all the individual ones, it's like 3 times the amount of the original people that died because there's overlapping causes, right? Kind of like the patient with pancreatic cancer who died of COVID because a distant uncle had it. I'll shut up. I gave this talk a long time ago, and I didn't have the slide in because I thought maybe it'd be a little too confusing, but I'll try and make some sense into it. You can report in statistics the manner of death, or I can report to you the cause of death. If I'm reporting to you the cause of death, right, it's not uncontrolled diabetes. Somebody died of a massive heart attack that took their life, right? The manner of death was, for the past 20 years, they didn't control their diabetes, they didn't get, their cholesterol taken care of, or, whatever. So the cause of death was the heart attack. The manner of death was uncontrolled diabetes, right? So if I just say, is it appropriate to say that somebody who died, came to the ER unconscious, they died, and I do an autopsy, and in their system was high-dose benzodiazepine, marijuana, fentanyl, cocaine, and then I go and tell you they died of opiates. Anyone got a problem with that? So how am I within my right to report that to you, as a statistician, to report that to you as an opiate death, as a cause of death rather than the manner of death, right? So it's an important, and I hate to do it, to draw the distinction with COVID, because they tell you they're reporting the manner of death as a cause of death, right? And you think, oh my God, there's all these COVID deaths, but they had a stroke. So again, if you look at the data of unintentional drug overdose deaths, right? So there's 1,400, right, in 2016. But if you look at the individual subtypes, right, there's 3,000, right? I don't want to show you a pie graph showing you the amount contributable to each individual cause when all of them are overlapping. How'd I do on that? Was that clear as mud? So another study sort of looked at, okay, let's look at post-surgical prescriptions for opiate-naive patients who get a short-term opiate prescription post-op. Let's not look at the death rate. Let's just look at the misuse rate, right? And bunionectomies are always ripe for this type of study because they're typically opiate-naive, and it's actually pretty painful surgery. But they looked at 1 million opiate-naive patients undergoing, in this case, it was bunionectomy. 570,000 received opiates post-operatively, and then they looked at misuse rates during follow-ups of 0.6%, not a death rate, just a misuse rate amongst opiate-naive patients. A misuse rate of 0.6%, again, doesn't quite hold the hypothesis that our prescriptions are doing this. Let's say, okay, well, maybe it's not opiate-naive patients. Let's look at a cohort of patients who are on high-dose chronic opioid therapy, and I'll bet you now we're going to find it. We're going to hold everything else the same, and we're going to find that this did it.
Sorry, go back to the previous slide. How did they define misuse?
Yeah, so during follow-up, if you had an ER visit and you got another opiate prescription, the general things that would, even if you had taken other drugs alongside of that, like street drugs or something, like if you had a bad urine test.
Were they UDS for how long afterwards?
So I will admit, for the patients who didn't ask for opiates after their 7-day course, they were counted as a non-misuser, right? So maybe it's skewed a little off, but we're not even talking about death rate, right? Yeah.
It starts with misuse usually, right?
So now let's look at chronic takers and high opiate doses. So this was in the Carolinas. Mortality rate amongst chronic opiate users, almost 2.2 million prescribed opiates, and a death rate of 0.022% per year, right? And of that percent, there was a 10-fold higher rate in those who were taking concomitant benzodiazepine, and no evidence of a dose-dependent risk depending on how much you were taking beforehand. So in epidemiology, we talk about attributable risk, right? So if I've got a risk factor for a disease, and I want to know how much of the disease I can avoid if I take that away, right? In this case, what, 0.022% of the opiate deaths, right? Not a whole lot. All right, so opiate addiction starts when they first get exposed to an opiate through us, right? So they did this is more of a descriptive study where they interviewed 27,000 OxyContin addicts who entered rehab from 2001 to 2004, and roughly 80% of them said that they were never prescribed an opiate beforehand, right? So 4 out of 5 of them had found that on their own. And opiate volume between 02 to 14 doubled, but rates of non-medical use stayed flat. So, all right, so again, we're trying to tap into your inner correlation coefficients. Overdose death rates, I showed you data in the previous talk that there were increased lockstep with prescriptions from the 90s. But if you look at a broader picture, I think somebody was bringing up, World War II, but if you look at the broader picture of drug use from the 70s till now, what you'll find is that the mortality rate from all drug overdoses have been on an exponential growth curve since the 70s. In fact, if you plot it on a logarithmic scale, the R value is 0.99. So if our assumption is that as our prescription rates started to increase, so did the overdose death rates, that certainly would have caused a blip and wouldn't have made such a huge correlation coefficient, right? And if you look at the left-handed slide, it'll show you that, along the time between the 70s and 80s, what people were dying from has changed based on what they were taking at the time. In the 90s, it was cocaine, and that shifted to opiates. So the knee-jerk reaction is to say, okay, well, let's get rid of the opiates, we'll fix the problem, right? I like learning from the past. When we had prohibition on alcohol, the government had mandated that alcohol companies put adulterants in their supply chain so that people would actually get injured if they tried to drink the supply. And it actually had problems because bootleggers were distilling this stuff and people were getting blindness from the benzene and stuff that they were putting in the alcohol supply. And even the New York City Medical Examiner said that the government knows it's not stopping drinking by putting poison in the alcohol. This is from 1926. Yet it continues the poisoning process. The harmful effects of this abuse deterrence fell disproportionately on the poor because they could not afford better whiskey and deal in low-grade stuff. Does that sound like it has any parallels to 100 years later? So actually, fast forward 100 years, when Purdue started at the behest of the government to create tamper-resistant OxyContin, the morbidity and mortality started to go up, as well as the use of street drugs, which have adulterants, right? The carfentanil, the fentanyl, kind of like the benzene of the alcohol, right? So we find that opiate consumption stops rising in August 2010. Heroin deaths begin climbing the following month after the abuse deterrent OxyContin was put into the supply chain. And growth in heroin deaths was greater in areas with greater reformulation access to heroin and opiates. The reformulation did not generate a reduction in combined heroin and opiate mortality. Each opiate death was replaced with a heroin death. So in other words, the reformulated OxyContin shifted people to the street to go find their drugs in the black market. And then again, Opana, or Endo, reformulated Opana to be abuse deterrent so it couldn't be crushed or snorted. And in 2015, 190 people in Scott County, Indiana, tested positive for HIV. Was the biggest outbreak in Indiana history, and this happened like within months of this being put out into the supply chain. And people, and the health officials in Indiana actually pleaded with the FDA to pull back on the abuse deterrence because they linked it to the sharing of dirty needles. Because again, you couldn't crush or snort the Opana, so you're shifting your usage patterns to more risky behaviors. So CDC recommendations, again, that's what we're dealing with now, something between a guideline and a recommendation. So essentially a guideline is something that, which I'm glad we don't find too many guidelines in medicine because it really ties your hands medical legally, but it's something that basically everyone agrees that shouldn't be violated. That there's no really good reason that you should do this versus a recommendation that says, you know, maybe some of the data is pointing towards this is a bad idea, but we recognize that medicine is a one-on-one thing and that there are individual circumstances why it may not work for this clinical scenario, and we don't want physicians to be in a bad spot if they determine that they need to go in another direction. The CDC recommendations that have come out are just that, recommendations, not guidelines. Interestingly, there were no leading chronic pain specialists on that board. And I know that when I was in Michigan as the director of pain for Michigan State, which was in the capital of Michigan, I was never asked my opinion on any of Michigan's opiate task force or what they should or should not do. So what happens to patients, and we talked a little bit about it in the last lecture, under this current culture, right? It's the war on opiates. Opiates are bad. But patients who are stigmatized coming in through the door, right, you can't have honest, open conversation with them, right? Because now you've got to do this, or now you got to do that, and the patients don't want to be, felt like they're a problem. They don't want to be thinking that they're, adding to the problem, and then they won't tell you about it. So if our prescribing rates are not adding to the opiate deaths, but potentially shifting them to more risky behaviors, and now patients don't want to talk to us about their behaviors or their pain or their psychological angst because we have this elephant in the room of the opiates, then they're going to find it elsewhere. And that has direct and indirect negative effects. So direct effects is people shift to black market supply, increasing the chance of opiate death. Because again, the problem isn't necessarily opiates as a subset of the overall intentional and unintentional overdose. It's a problem of they don't know what they're taking, right? The black market. If I go and I know that my Purdue Percocet, last weekend at that party made me feel like this, I go to take that again, but now it's an adulterated pill with carfentanil in it, even though I don't maybe necessarily have a problem, it's non-problematic use, unintended death. Again, legitimate patients can't pursue the treatment plan, right? And we talked about, somebody had this question about, You know, what about a patient who only takes 7 Norco in 6 months, right? Now we're making that patient feel like, man, you know, I take it like, you know, once a week. I'm out gardening. It's really bad. I take one. Now, so to this week it was 2, and now I got to come back and see you early, and now you're talking to me about an early refill. So just, again, a legitimate patient who, you know, didn't really part of the problem is now being roped into it and feeling like they're part of the problem. Increasing costs for increased ER visits, medical visits for non-medical use. I probably don't have to tell anyone that. Expensive lab tests. Pain behaviors are complex interplay that involves multiple factors. Patient experiences. We talked about, you know, whether or not what you've experienced before. Psychological and societal. If we narrow our focus on opiates, we may miss the underlying culprit. We talked about the Skinner studies with the rats, and when we can't communicate with patients and get to the root cause of them finding their own, you know, sort of purposeful life, then they're going to try and numb it other ways. And I think probably the opiate use data over since the 70s is probably more indicative of something else going on than it is necessarily of this narrow window of 10 years that we're focusing on opiates in general.
What advice do you have regarding patients that admit they smoke weed, come off with SSRI, tricyclic, they don't want a benzo anymore? What can I legally and medically still give them? I mean, if they have long-standing neuropathy, lyrical, medically and legally, where am I putting myself? If I give them a little Lyrica or a little Gabapentin, but they don't want benzos, they don't want opiates, and they say, this takes care of me, most of them, but I still have this one issue.
I mean, I guess it depends what that issue is, right? I mean,
Well, so, neuropathy. If it doesn't, they still want Lyrica or Gabapentin.
okay, so, well, Lyrica and gabapentin are Schedule 5, so most of the requirement stuff from the first lecture applied to 2 through 4. So it's not quite as bad of, you know, having to deal with all the minutia of it. There is and the reason why at the beginning of this lecture I really wanted to focus on the interplay between sensory and emotions is that there is a psychological, there's a very strong psychological underpinning, and I probably should have put some of the data in here about from the anesthesia literature. So if you look at patients who, if you take patients and you essentially randomize them, who say they're having the same type of surgery, and this has been documented over and over and over again, and then post-op, you give one group of patients a narcotic that they have to buzz the nurse when they need it. The other group of patients, you give them patient-controlled analgesia, right? You give them a button to press. They've always got the button, and you plug in the same narcotic parameters that they can get if they buzz for their nurse, right? And you look at their opiate use, their quality of life in the hospital, which is like happiness and satisfaction, right? And you look at their opiate usage, right? So all things being the same, patients with patient-controlled analgesia report lower pain scores, better satisfaction, and use lower amounts of opiates than patients who had to buzz for their nurse. So, I mean, this is holding all other factors equal, right? So even though opiates don't necessarily, according to studies, play that huge of a role on the neuropathic pain pathway, right? It's what you're talking about. Somebody has a hot radiculopathy, they have spinal stenosis. Sometimes giving them that button gives them a sense of, control. If it really gets bad, then I can take my hydrocodone. I'm not saying that when they come back it works, but it gives them back that sense of something they can do over their pain. But yet, we're going to get hammered for that, right? Because opiates aren't good for, neuropathic pain. But then the problem is then they come back and they say, well, my friend gave me this, try this, and then all of a sudden they're mixing a bunch of things, they don't even know what they're doing.
So I have kind of a question and a thought. In family medicine, I've been treating opiate dependency with, brand Suboxone or buprenorphine naloxone for 15 years now, and grew tired of it's almost like a game. If you do it for so long, I don't really find that patients are actually taking all that they're prescribed, and they're, sharing it, and I can't control that, but I believe the condition exists. So I switched to only buprenorphine injection monthly as a principle. I just decided to do that about a year ago, and my new patients went down to almost none. Like 1 a month, 2 a month. And so from what you're sharing up here, I might actually be doing harm because I'm not putting something safe out there for people. But I just wanted to, you hearing that, does that sound like a great principle and way to treat, or does that sound like a terrible idea?
Again, it depends on who you believe has the autonomy to make personal health decisions, right? I mean, before there was all this government regulation and all this things that force people's hands into certain healthcare decision making, still was just offering a treatment, right? Right? And then sort of word grew, hey, this kind of works. And they told their friends, and maybe it would come, maybe it worked, maybe it wouldn't. It was organic, and it sort of, followed the same thing. But at the same time, during that time, you could go out and buy Samantha's Elixir, right? Which was a low dose opium, so you didn't have to go to a physician, right? So the only patients who came through your door was the ones who wanted to see you and wanted your opinion and wanted to see what you could offer them. But today we see patients through all these different lenses of we're the gatekeeper, we're the paternalistic, we're the responsible for society, we're responsible for your opiate death, we're responsible for and it's hard to tease out through all those lenses. It's why we're burning out, right? Probably, I could take a poll of the room. How many patients you see a day, what percent do you think are there because they value you and what you're offering to them, or because you're the one who gives them their anti-anxiety meds and their blood pressure meds, right? I'm saying it's kind of painting a grim picture. I don't think you're doing anything wrong, but again, you're saying, okay, I'm going to treat those who really want the treatment for your problem, and you're finding out when you do it and they don't get other gain from it, they don't want it. I would say you're doing the right thing, but maybe, I guess what I'm saying is maybe the market for it isn't as strong as you think it is, right? It's an opinion. I'm not saying I got the right answer for you.
I just had a question. As more states are legalizing marijuana, I've got some kids that are on stimulants or, on benzos, and so they come back and I'm like, hey, I need to drug test you, and they're like, oh, by the way, I was in Virginia over the weekend,
Mhm.
and I did smoke a joint, so just so you know, doc, and they're completely honest with me about it, then I, confirm that, oh, well, there's a little THC in their system, okay. How does that make me liable? Like, what should I do in those situations? Because they're telling me that they're being honest, they were doing it legally, but in the state of Tennessee, it's illegal. So I just document and say, this is what they told me.
So this is probably, this hits right to the whole foundation of the 2-hour talk. And that is, by all this documentation, we're treating the guidelines and recommendations and not the patient, right? I think if there's one thing I wanted you to take away from this 2 hours, is polypharmacy is really dangerous, right? I can't tell you that people are dying from opiates when they have cocaine and heroin and benzodiazepine in their system. I don't know what tipped the scales, right? But what I do know is this. If you're on marijuana and you're on opiates, and I give you a Flexeril rather than a baclofen or Robaxin, right? That's more sedating, and then you get a tricyclic antidepressant for your neuropathic pain, and then 1,800 milligrams of gabapentin. I mean, hell, I took a 5 milligram Flexeril probably, 10 years ago. I got like, oh man, my neck. And I woke up like 10 hours later, like, my neck still hurts, but I try not to prescribe it ever since then, because I'm like, this ain't muscle relaxant, I just don't know what happened. And that was a 5 milligram Flexeril. I mean, I got patients on 10 TID, right, with 10 Percocet QID, and, a milligram of Xanax TID. And I'm like, how are these people walking around? I can't handle a 5 milligram Flexeril. So I will say, from a medicine point of view, with every patient who comes through my door, I call it a sedative inventory. And, it doesn't matter whether you're family practice or pain medicine, if you got somebody, if you're in family practice and you got somebody coming in and their A1C is 14, right? And, you just know they're not gonna exercise, right? Then what do? I'm gonna start you on metformin. I'm gonna just risk reduction, right? You're probably better off eating like a pig with some metformin than you are playing this stupid game that you're not gonna exercise. And in the meantime, you're gonna have a heart attack, or, and then I'm gonna add this, I'm gonna add that. I'm gonna tell you, hey, you really should exercise. But now we're going to add metformin, and now we're going to add Lipitor, and we're going to, we're just going to try and reduce the risk as best we can based on, what you're doing. It's no different in, like, pain or your lifestyle. Like, hey, look, man, you're on these opiates, and you're smoking this pot. Number one, it's illegal, and the fact that it's in your system puts you at risk. And I can't keep adding to your risk. Like, hey, okay, if you're going to do pot, maybe I'm going to switch you to a Butrans patch. Maybe something that, and risk reduce you, right? I'd feel a little more comfortable with that anyway than the Percocet. But if you do that inventory and if you take a quick step back and you're like, ooh, we're kind of sedating the bejesus out of you, maybe Scalaxin is better than your Flexeril. Maybe this Butrans patch is better than your, hydrocodone. Maybe I should put you on Cymbalta instead of the Elavil, right? You just trying to shift the polypharmacy towards risk reduction and safer things, because maybe they're doing okay with their pain, but you're just trying to shift them away from that polypharmacy that we know is hurting people.
I've seen it more with younger kids, college age, that are on stimulants, and then they go and they're like, well, and I've drug tested them in the past and it's always been clean, and then they go to Colorado, or they go somewhere with all their friends, and then they come back and they're like, oh yeah, I didn't take my stimulants over the weekend, of course.
Yeah.
Doing my holiday, but I did smoke a joint.
Well,
And those are the situations where
yeah.
I'm like, well, geez, now you made it really tough on me.
Right.
If
I just approach it from a medical standpoint. I say, hey, look, man, I got you on this stuff. It has some real risks. If you're choosing to add to that risk, I can't be part of it, man. You gotta work with me here. And if we're going to continue to do this, I got to make sure you're going to do it safely. If not, I can't. It has nothing to do with government, right? Just make it about them, right? You know, like, hey, I can't have it on my conscience. You know, if you're going to sit there and go out and try a bunch of stuff and not give any consideration that I'm giving you amphetamine, and you might put yourself at risk. If you're not going to take that seriously, I'm not going to take prescribing it seriously. I need something from you too, right? You got to roll in this, and the Supreme Court has ruled on that. Some family tried to sue their family doc because their family member died of a heart attack, and the family doc didn't talk to them enough about smoking cessation. You laugh, but this was a Supreme Court case, and the Supreme Court, said, like, basically, a physician's got to tell you, the risks, benefits, and alternatives. But at some point, that's your body. I mean, you either got to take it seriously or not. And as the physician, you say, hey, I'm treating you seriously. But if you're not going to take the treatment seriously, then we can't do it. I got to know that okay, you've got a problem with focusing. That's fine. We're going to work on that. But this treatment has, some things that are risky. And if you're not going to take it serious, I won't. That's kind of how I approach it. Yeah.
I might actually make a comment. So, and I think it has to do with part of what you were talking about with your slides. You were talking about how with these individuals, how we've just decreased our opiate prescriptions, but we've seen the deaths go up. You know how you referred back to like how we have created the rat study and how you created those supporting systems to be able to help those rats to make other choices. I guess that's the other question would be, is what have we done for those patients as we are decreasing the opiate prescriptions to be able to support and first of all, identify those patients, help support them to be able to transition?
Again, I'm going to start off by saying I'm a government skeptic. So every time I hear the word we, I cringe a little bit. I sympathize from the bottom of my heart for anyone who's going through trouble. I really do. But, we've piled up enough on our shoulders dealing with that I don't know. I try and stay in my lane, right? Like, hey, if you're struggling, I really want to get you in with somebody. But again, if you're not going to take it serious, I'm not going to take it serious. Because this is your life, this is your body. If you're going to continue to just mask all your problems with whatever's going on here, I'm not going to be part of it, right? But I'd love to help you. But if you're not going to help yourself, we don't owe you anything. Is that harsh? It's too harsh. Not too harsh.
I think in some ways I'm actually happy with the government in terms of putting some regulations down, because when I was in training, I actually did an OB fellowship, and when I was in training, I had 5 of my obstetricians come up to me to tell me that I was not giving enough post-op prescriptions of narcotics, and they were requiring me to prescribe oxys and Dilaudid, and they wanted me to give 30 days worth of prescriptions, and all of them actually took over prescribing because they felt like they were prescribing enough. So that was really frustrating because the patients because I was rounding on those patients, right? So a lot of those patients that I saw where they had the option to decide what they wanted in terms of their pain control. The patients that were taking the higher dose of prescriptions were the ones who had the worse off recovery period, because all they did was to try to mask their pain. And what we found rehabilitation, post-op recovery, those patients that would get up and get moving did better overall than those who were just taking whatever pain pill and just laying in bed and just focusing.
I don't disagree with you. Before I take the next question, I don't think I've said it yet. SVMC, if you have your insurance through them, sitting through the talk, if you fill out they give you a nice little discount on your insurance if you fill out your form and turn it in.